Well, hello and welcome to this month's podcast, where, as always, we're going to bring you up to date with the latest information and data in the world of rheumatology. And joining me today is a fellow member of the IMID Forum Steering Committee, Professor Maurizio Cutolo, who is Professor of Medicine Rheumatology, Director of the Research Laboratory and Academic Unit of Clinical Rheumatology, and Director of the Postgraduate School of Rheumatology at the University of Genoa. Maurizio, a warm welcome. Nice to see you.
Thank you, Iain. Welcome.
Always a pleasure. Now, in today's podcast, we are going to be reviewing two papers that cover important topics in rheumatology, as always. Our first paper is from Roy Fleischman and colleagues and presents 5-year efficacy and safety results for upadacitinib in rheumatoid arthritis. And then in our second paper, Laura Andreoli and colleagues provide a comprehensive overview of the literature and guidance in discussing outcomes of children of mothers with autoimmune rheumatic diseases. Interesting area. And as ever, to access detailed summary slides for the papers discussed today, please visit imidforum.com. As always, it's imidforum.com. Okay, well, I'm going to take the first paper. It's the long-term safety and efficacy of upadacitinib versus adalimumab in patients with rheumatoid arthritis, 5-year data from the phase 3 randomized select compare study. Now, a little background here. I think you're probably pretty familiar with select compare now. It's an ongoing double-blind phase 3 study evaluating upadacitinib, 15 milligrams per day versus adalimumab, 40 milligrams every other week. Oral and subcut, obviously, both in combination with methotrexate in people with an inadequate response to methotrexate monotherapy who have rheumatoid arthritis. Now, upadacitinib has demonstrated efficacy with an acceptable safety profile in the phase 3 select clinical trial program with patients with rheumatoid arthritis, including in the select compare long-term extension through 3 years. And this study assessed the safety and efficacy of upadacitinib versus adalimumab from select compare over 5 years. Eligible patients, that was 1,629, were more than or equal to 18 years of age. They have active disease and stable dose of methotrexate for more than or equal to 3 months. And they were initially randomized in a 2:2:1 ratio to upadacitinib 15 milligrams, placebo, or adalimumab 40 milligrams every other week. And patients who didn't show improvements in tender joint, swollen joint, or did not achieve LDA were switched to adalimumab or upadacitinib up to week 26. And all patients still receiving placebo at week 26 were switched to UPA. Now, patients who completed 48 weeks of treatment could enter an open-label long-term extension for up to 10 years on upadacitinib 15 milligrams per day or adalimumab 40 milligrams every other week. Efficacy endpoints assessed through week 264 included the proportions of patients achieving LDA, CDAI less than or equal to 10, or remission, CDAI less than or equal to 2.8. DAS28 using the CRP measure of less than or equal to 3.2 or 2.6 respectively, and ACR 20, 50, and 70 responses. Changes from baseline in various ACR components were assessed, and that's of course, very well known to you: tender joint, swollen joint, patient's global assessment, physician's global assessment, both of the disease activity, patient's assessment of pain, HAQ-DI, high sensitivity CRP, morning stiffness, and duration of morning stiffness. And well, the results, the rates of treatment emergent adverse events were generally similar with upadacitinib versus adalimumab. Rates of herpes zoster, lymphopenia, CPK elevation, hepatic disorders, these were transaminase elevations in the main, and non-melanoma skin cancer were higher in patients receiving upadacitinib compared with any adalimumab. And at 264 weeks, a significantly higher proportion of patients initially randomized to upadacitinib achieved CDAI remission compared to adalimumab, 24.6% as opposed to 18.7%. A significantly higher proportion of patients initially randomized to upadacitinib achieved DAS28 CRP less than 2.6 compared to adalimumab, that was 31.8% versus 23.2% respectively. And proportions of patients achieving ACR 20, 50, and 70 were consistently higher in patients randomized to upadacitinib compared to adalimumab. Now, these outcomes are also numerically higher in patients who switched to upadacitinib versus those who switched to adalimumab. radiographic progression was numerically lower with continuous upadacitinib versus adalimumab at week 192. So what do we learn from this? Well, we're continuing to see a consistent safety profile. I would always refer us to larger data sets. The clinical responses are numerically higher. Very difficult to know what that means in a 5-year long-term extension study. And at present, this would certainly support continued use of upadacitinib in patients with rheumatoid arthritis. Notwithstanding that, we do have to be very aware of black box warnings that are in place. So that's the paper. Maurizio, anything that immediately strikes you about this? It's another long-term extension. It's more looking at trial data as opposed to real-world evidence, and it has to be seen in the background of the black box warnings. But what are your thoughts, sir?
But I was questioning to myself and reasoning. Of course, we compare totally two different drugs with different mode of action, half-life, and so on, so on. But when we compare each day drug versus other week, so of course we should expect different safety profile and different efficacy, probably, because it's clear that shorter a life means sometimes less side effects, and shorter of life, but every day may be an intervention on the symptoms, at least, of the disease, much stronger and earliest. So I was questioning if even for other study, of course, this is just this example, but when we compare different drugs, it's okay. We look at the efficacy at the end after 3-5 years, but looking at the side effects, well, here it's very difficult to say which one of those it's safer, because the papers say, yes, the well-known side effects of UPA were observed, and we know they are much more than for any other DMARD. So at the end of the story, the advantage seems that when you start with UPA, you achieve a minus 2.6 results for the clinimetry much faster. But what about the side effects? You obtain also the side effects much earlier, slower, compared to the other approach. This is my question. I don't know what you think about.
Yeah, well, I mean, I must say, the way I look at this is there were higher rates of zoster, lymphopenia, CPK, hepatic disorders. And I'm also not entirely sure what to make of the non-melanoma skin cancer data. I think that's something that we're looking at across a wider literature at the moment. So this is more seen as a non-negative. So I don't think this puts me off using upadacitinib. I don't think there's any serious signal here. But I think we do need to continue to be very vigilant. And I actually agree with your point about I'm not sure whether it's the half-life or route of administration specifically, Maurizio, I don't know quite how that plays out. But the different modes of action, I think we would anticipate they will have a different adverse event profile. It would be very unlikely that we'd be able to have an effective immune modifier that didn't come with some consequence on immune modification. So as I say, I wouldn't read too much into this beyond it's more data, it's more trial data, and provided we continue to use these medications within their approved indications, I think this continues to be a reassuring message. But we'll see how it plays out. Always we have to be conscious that long-term extension data are very much contextualized within the kinds of patients who could be recruited into a clinical trial. And in the real world, where we have many more comorbidities and all the challenges, that's really very important. Well, look, Maurizio, let's move on now. And I know this is actually an area that's been of interest to you for many years. So I'm going to suggest that you talk us through the paper concerning outcomes for children born to mothers who have an autoimmune rheumatic disorder. So maybe over to you for this next paper. Thank you.
Thank you, Iain. Yes, this is a very, very, very stimulating, important, even from the social point of view, to discuss the possible outcome of children born from mother with autoimmune rheumatic disease. From the literature, before I enter in the details of this paper, I can say that we know already very well that the outcome for the different autoimmune disease is not similar for each disease. For example, it's much more frequent to get problems in a mother affected by systemic lupus erythematosus with antiphospholipid syndrome than mother with the pure arthritic form of rheumatoid arthritis, even maybe an improvement during the pregnancy. And this is due to the balance of the endogenous hormones that exert epigenetic effects on the immune system reactivity. So, for example, I expect much more problems for mothers with autoimmune disease in which the adaptive immunity is strongly activated than in mother the disease is mainly based on innate immunity with lower activation of B cell, production of autoantibodies, and so on. That is why, because estrogen generally tended to enhance the B cells reactivity and antibodies, so it's easier in the patient with lupus to get complication and even risk for the fetus than in rheumatoid arthritis, where estrogen down-regulating on T cells. Usually, this is the difference immune action of estrogen. And we know the placenta is an endocrine organ that produces a lot of estrogen, testosterone, progesterone, and corticosteroid. But this is what short, sorry, just a little introduction to say that in this paper, they describe autoimmune rheumatic disease altogether. But probably it's better to know that it's not so generalized what happened during the pregnancy. In any case, the paper underlined that, of course, maternal pregnancy complication may induce problems also in the newborn and infant over the time. And children and adolescents can be addressed versus a range of different and totally different disorders like spanning growth, somatic, neuropsychological development, and even the risk of autoimmune disease once in the life themselves. It's clear that the appearance of an autoimmune disease, it's related not just to the genetic factor, because it should be too easy and too catastrophic, but the possibility of the other risk factor during the life of the babies may influence epigenetically the activation, methylation DNA, and so induce the expression of genetic inherited genes from the mother to express again an hyperimmunity and in strong immune response. So this is why the mother asks always, when approach the gynecologist or the rheumatologist, if there is a risk, if she will get a baby, that the baby also will be affected by the autoimmune disease. And this is absolutely a little gamble sometimes, because it's difficult to predict from the beginning. We know for many inherited disorders of trisomy 21 that there is a risk, thalassemia, but for the complex immune diseases, it's difficult to identify all the risk factor and gene involved in the possible activation of the immune response in the sense of inducing autoimmune disease. Anyway, this important review refer that the risk of preterm birth, low birth weight, and other disorder of the immune system are always possible in this case. And this depends on what kind of therapy was before the conception and during the pregnancy, because we know that some drugs like glucocorticoids may be permitted during the pregnancy because they don't induce risk of teratogenesis or real risk to the implantation of the placenta. But other DMARDs are teratogenic, And some of them are very dangerous for both mother and children, because an abortion is always a danger for both, a problem for both of them. In any case, we can say that generally the rapid catch-up in weight for length during the first year of life is associated with high disease activity during the pregnancy. This is an important aspect. Another aspect, no reduction in bone mineral density was observed in children when they were aged between 5 and 10 years, but an increased risk at least of juvenile idiopathic arthritis or type 1 diabetes. They are all mediated by, we know, by the immune system, but even asthma in children of parents with RA, it's possible. So we see that there are several possible consequences of pregnancy during in women affected with autoimmune rheumatic diseases. We have started 5 years ago, and now almost finished, with the Zurich Center led by Caroline Hospelt, a study evaluating the epigenetic, can I say, replay of the methylation DNA at the level of monocyte of the patient with systemic lupus rheumatoid arthritis over time versus normal pregnancies, just to see if it's possible to identify, for example, particular marker, epigenetic marker during or related to the risk of abortion, of other problems, because of course this pregnancy we collected in 4 different centers were associated with different outcome of the pregnancy. So Caroline has just finished the analysis. Would be very interesting to see which kind of epigenetic changes may be associated, because all we know, the genetic is important, but today it's much more important to know how epigenetic modulates, switch on, switch off the genes. And so pregnancy, I said, is a gamble, because if we can anticipate with epigenetic biomarkers, and we know the risk factor for such a disease, would be better for the mother and the outcome of the children, because we can anticipate at least some of the problem or the positive outcome. So the review concluded, in any case, the review that we by Andreoli, that it's important a team work with the patient, of course, in the middle, but also gynecologists, rheumatologists, eventually also immunologists and expert in genetic, because this is, I think, today the real way to anticipate in medicine and to prevent. This is.
Now that's great, Maurizio. Thank you very much indeed. Yeah, it's an important review. I think what I'm hearing from you is that it's very much a work in progress, though. And I certainly, when I looked at this, I'm a much simpler guy than you. You know that. I think if I were just the general practitioner, the rheumatologist out there working, I think my sense of this is that it's going to be vital for us to tell our patients what is known, but also what is not known. So just be honest with them. Be clear that there are still gaps in our knowledge. And that's probably quite important, isn't it? Because our patients do have anxieties. They have anxiety about so many elements and impacts that their disease has on their own quality of life, and then how much that is accelerated when they're worrying about the impact it might have on the next generation. And my sense from the review was that by and large, we can provide fairly significant reassurance that the increased risk is not necessarily going to correspond from them into increased risks in their children. Yeah, there are features, and you've highlighted particularly concerns around placental health and placental well-being and some of the endocrine impacts, and also I think epigenetic impacts. But in general, it looks that as if the risks are going to be low, but they're not absent, and that's the problem, isn't it? And I guess we should also make sure that patients are aware that disorders and conditions can occur and be ready to address them. So preparation, looking out for factors, and to make sure that they do report things. And then there's a balance of making sure that they don't over worry about it. But all of this is the critical element of communication, isn't it? Communication between the treating team, I guess also the obstetricians and pediatricians and rheumatologists, because it's also, and I think self-evident from what you've said, that the earlier we pick up challenges, for example, manifesting failure to thrive, growth not manifesting as we'd like, the earlier a diagnosis and interventions, then the better the prognosis. So it's a really important paper. I guess over the years, though, pregnancy has always, and then the consequences of pregnancy, the newborn and early growth, I think it's still one of the hardest conversations I can think of in the clinic, because we've got to be honest. And when we're being honest, we can't give absolute reassurance, although we can try and manifest some confidence that the risks are probably going to be very low. And then, of course, it's the art of medicine, individualizing that. I don't know what you think about all of that, but that's where I got to when I listened to you and having read the paper.
Perfect what you say, but the good news is, real good news. Today, we treat rheumatic disease, autoimmune rheumatic, much better, and remission is much easier. And the same should be for the unlucky baby that unfortunately got from the beginning. We can stop very easy and without any risk. So it's true, there is a low risk, but even if something goes in the wrong manner, we can treat today much better than in the recent past. And so to block the disease like we do with hundreds and thousands and millions of people that start to have an immune with targeted therapy, an autoimmune condition.
Oh, fantastic, Maurizio. And a particular pleasure to have the podcast with you today, because I know this is a subject that you have thought about a lot over the years, certainly more than I ever have. But look, thank you ever so much. Two really interesting, very different papers today, but very interesting. As always, my dear colleagues, if you want to look at the publications uploaded this month and access all of the other podcasts and resources, head over to imedforum.com, and don't forget to subscribe to the Immune-Mediated Inflammatory Disease Forum podcast channel. Make sure you don't miss out on podcasts in the future. You wouldn't want to be doing that now, would you? And as always, make sure to let us know what you think by leaving a review. And thank you so much for your attention. Maurizio, thanks ever so much for joining me. Always enjoy a good conversation. And finally, to our audience, wishing you the very best, because at the end of the day, the imedforum.com is really all about improving the care of our patients. That's what matters, and that is what's absolutely at the front of our mind, interpreting the literature to improve the long-term quality of life and outcomes for people with immune diseases. So thanks very much indeed. Take care for now. Bye-bye.
Goodbye. Thank you to all. Thank you, Iain. Enjoy.